afternoon. We are now in small numbers, but I still hope we can have some fruitful discussion. I will try to present some ideas about interprofessional collaboration, some issues, and probably also one of the practices where this collaboration now is in fact working quite well. For the commercial, for the promotion, I put some nice spots. I hope you visited this part of Ljubljana. Then Bled is a must if you visit Slovenia. There isn't my own hometown place, Kranjska Gora. This is a small piece of Adriatic coast that belongs to our country, and the city of Maribor, where the second university is, and medical school where I'm head of the department. Let's start with the history, and then it will take us ages to come to today. I have to mention Yugoslavia, but not only Yugoslavia, before 90s. This is the country that becomes part of the territory after the First World War. At that time, the country was put together from three parts. One was Kingdom of Serbia, the second part was Kingdom of Montenegro. The King of Montenegro abdicated in favor of Serbian king, and the part that was majority populated with Slavic people, Serbs, Slovenians, and Croats. These are parts now of the countries Slovenia, Bosnia, Croatia, and northern part of Serbia. The development of healthcare system in the 20s was very bad in many European countries, but especially in these territories was devastated. Many doctors in the north-west parts of the Yugoslavia were German-speaking. That doesn't mean that they were all Austrians, because the major universities at that time were in Vienna, Prague, and Krakow. So also people from Poland, Czechia, and Hungary were serving as doctors in these parts, but after the war they retreated to their own national or native countries. Same was with Serbia. There were low numbers of doctors. So the country was devastated after the First World War, as any other country in Europe, and the healthcare system was quite weak. A guy named Andrija Štampar, who was a Croat, coming from today's part of Croatia, Slavonia. He was a kind of a public health doctor. He recognized the problems and he developed some things I will explain later. And he was so popular at that time. If you can imagine, this was a completely new country, but he was so popular with his ideas. So he was employed by health organization in the 30s. So his ideas at that time were breaking through, and also after the Second World War he was elected as the president of the WHO Assembly. So this is history where the ideas of our project are coming from. So what was at that time an important issue? He brought up instead of doctor-centered care, so the doctor is working for fee, patients are coming, they are paying things. Okay, we have to stress that in the northern part that belonged before to Austro-Hungarian Empire, there was a Bismarckian system of insurance. So working people in organizations, in big organizations, they had some insurance. Like it was introduced in the latest 19th century, but after the breakdown of the Austro-Hungarian Empire, also these things were dissolved. And the problems were like many would see that the problem of child mortality, mother mortality, tuberculosis, the only thing that is not important anymore is trachoma. This is eye infection that was at the time very often in the territories of this country. They also noticed big problems of housing, how people lived. For example, outside the house there was a stable for pigs. Adjacent to this was the closet, and close to this was a water source. So the education about sanitation, all these things was very important. About nutrition, opposite to today, when nearly half of the population has too much energetic intake. At that time there was not correct food. Probably at that time was also the problem of using too much corn, and only corn, and the deficiency of B vitamins. So it was very important that in these health centers that were organized at that time, that they took care about the mothers, about expectation, well babies, and treating these diseases in the possibility of that time. Very important was also education and health promotion on the voluntary basis. And there was an universal access to the clinics for the poor population, also for the curative things, because these doctors were public servants. So after the Second World War, we came to the part of the world where socialism was as a kind of ideology introduced, and social medicine and socialism are good mates, because in socialism the importance of healthcare was a kind of a driving force, or the main flag of being successful at that time. But the continuation of this led to the split of these primary care physicians to gynecologists, pediatricians, and so forth, because those who specialized were better paid. And it was interest of doctors to get specialized, to get better payment. It's like nowadays we discuss about the classes where we are in payment classes, and in the 60s this connected also with the development of polyclinic system in the West and in the East. So we ended with the GP, who at that time was not needed to be specialized. However, the first specialist training was introduced in the early 60s. The first specialist came from Croatia, and also in the 66 we started having our society, at that time General Practice Society, part of our Doctor Society, and also specialist training. That was not mandatory. So when we started 21st century, more than half of GPs were specialized in general practice, having 3 years training, but half of them were not trained, and this then led to some political decisions which I will not explain now because it's not our prime focus. We got leftovers of others, so we got things that other disciplines didn't want to work on. And this is the reason why we have to do the coroner's duties, the emergency services, and stuff that was not attractive to those who wanted to work only in the morning and have a nice job. So, socialist tradition is not only splitting these professionals, but it's also investment in premises. If you were traveling our country, you would see that nearly in any town that covers the size of, let's say, 15 to 30,000 population, there is a nice health center with the facilities for everybody in it, all the disciplines, and many more. Because this was the time before the crisis of the energy crisis in the 70s. These are mainly large buildings, very spacious, that produce a lot of costs. But the tradition was quite traditional. very Central European oriented. So the doctor is the, let's say, the chief, the one who is the leading one, and the nurses are adjacent to help to do. So it took quite a long time that we got some kind of a breakthrough, that all the disciplines in a way now try to get and work together. Oh, in that time also the idea of general practice developed, and family medicine. And if you speak about comprehensive care, and if you remember what Eva told us, it's always a question. Shall we split a man in different parts and work in a polyclinic system, or do we specialize in some things, or do we need specialized GPs and so on? This is always a theoretical question. Or do we, or can we manage a person, a patient as a whole person? So it's always then also a question, do we need this kind of splitting and clinics in modern primary care? So we think that it's not the clinic itself, it's the approach, comprehensive approach, that is important, and we need it for issues that are not directly related to the patient demand. So patients usually come to the practice if they like to, if they want to, but we need to attract them for the health education like they did after the First World War, but we need to focus on things that are important today. So that today chronic vascular diseases and other non-communicable diseases are important in our part of the world, in other parts of the world, other things. And management of chronic patients that was presented, and especially quality improvement, that is, it can be done easier than it was. So, competences of GP or family practitioner are to use comprehensive approach, to be oriented towards community. So, here are chronic health problems, numbers are big, health promotion and disease prevention, and management and coordination of care, which is probably the biggest challenge in modern medicine. Again, we have to be oriented to the community and how to meet health needs of the individual patients and the community if we are paid on a basis that is determined by some insurance or anybody else. And to translate it into everyday practice, we see that these are unhealthy lifestyle, many undetected risk factors, and a lot of chronic diseases that can be treated today. In the past 20, 30 years, the medicine developed so much that we can treat things that years ago were little. Again, health promotion, which takes time. It was mentioned how many minutes a nurse needs and so on. And if you don't act, somebody else will act on our behalf. So we need some models of primary care that are tailored to the situation in a country. We listened to good explanation about the Swedish example, and also UK has a tradition of clinics. That means that you organize some things separate from walk-in, and they have a practice nurse that works her part of job independent from a GP. So there is not necessarily that we have a linear model like we have it in the Eastern countries, a nurse, a doctor, back to nurse, and home. So, to give a few words on the development of this. The development of family medicine in our country was gradual, with many impact of many doctors. But I can say that it started in the 90s with establishing general practice department in Ljubljana, and it took us 15-20 years to persuade and to find dedicated politicians, and we were able to introduce this clinic family practice thinking. And mentioned already today assistant professor Tonka Popla-Susic, she was in a lead position, and all others we were helping and contributing our ideas and managing the project group to come with this solution that we have now. A family practice team, one doctor, one practice nurse, and one full-time nurse practitioner with bachelor degree or something like this. It's very difficult for the terminology because in many different languages there are different graduates, but this nurse practitioner has all the capacity and knowledge to work the job. So here are listed some activities. On one side, screening and counseling and health promotion. On the other side, routine management of patients with some stable chronic diseases. The major issue is that now there are so many things to do that the nurses cannot cope with them anymore. But we are still in the project phase, and we are looking for solutions. But at the moment, we are happy that at least we started this, and we hope that in 2020 or 2025 we have all the practices staffed with this. This is just a brisk overview of very old data, because the major problem of the project is that we feed a lot of data in our computers, but we don't have systems to get out the data in a manner that we could compare the results of process that is done in these practices. I would like to show the picture. This is the project leader, Tonka Popla-Susic. This is a health minister at that time. This is secretary of his, and it's not important for the project. But I would like to stress that this is, in a way, a key figure, a political figure that was helpful and was so brave to go to the government and to persuade them that this is important. What to add? That only a few patients or only a few people do not have any risk factors. So that means that at the beginning there will be much more work than it used to be. And another thing is about let's say, the quality of work for each of the diseases or health promotion activities. Nurses had produced guidelines, protocols, and they work on these protocols for our patients. What are the challenges and shift in thinking? So it's teamwork. There was some discussion, what is teamwork, how is teamwork? But first is to recognize each other. And the next, what is another important thing, we can work very good in our practice. It's also important that we work on a national level, and on the national level this is recognized. And I think this is one of the first successes. We hope, and I hope, that quality assessment of our work will be feasible in due time, because at the moment, as I mentioned, it's very difficult because of the lack of the adequate information structure for the analyzing. We organize additional modules to train nurses, and we lack, in a way, motivation and training for doctors to comprehend and to work more closer with our nurses. So, why do we need to speak about professional clinical practice and education? Because this will assure and improve mutual respect. It's not that we are working on somebody's behalf, or we work for somebody, or that we still work for somebody. We have to share skills, knowledge, because we possess some different skills. We have to enable shared decision making, to negotiate how and who, it should guarantee accountability of everybody. So if somebody works on behalf of somebody, the other one is not responsible. So if we speak about collaborative practice, that means that everybody is accountable for what he or she is doing, and this surely makes better work environment. And however, what is our aim of work and quality improvement is assures delivery of good or improved patient care. So to say, we shouldn't not reinvent the wheel because many solutions are already there. It's just about stepping forward, shake each other's hand, discuss, and go for mutual better work for benefit of our patients, populations, and in that have alliance in other countries, from the experience of other countries, respected colleagues, and do not forget about the public support and especially political support. Thank you very much.